I think managing radiation is very important, particularly in the operating room, because stone patients globally are exposed to radiation recurrently throughout their lives. They get CAT scans, they get x-rays, in the operating room we use fluoroscopy. I think it's particularly relevant when we do our percutaneous procedures. Some of those patients can get exposed to very high doses of fluoroscopy, particularly during challenging cases. And people have been working on reducing the dose with CT scans, but it's often neglected in the OR. And so we started really thinking about what we're doing in the OR and what's really necessary and what's excessive. So in the context of a case, for instance, the patient who's middle-aged male with a large staghorn stone who's going to require a percutaneous procedure, the considerations to help reduce radiation are, one, to make sure you have good preoperative imaging. It helps you make sure you know where you're going to gain your access, at what points, so that you're not struggling during the case. In this particular case, we knew we would need multiple accesses to effectively treat the stone. And so understanding that you're going to do that ahead of time and being prepared to place them and understanding roughly where helps reduce the risk, the amount of fluoroscopy you need during the procedure. And as it relates to radiation, one obvious thing that's important is the emitter of the C-arm should be under the table. And we try to position the patient and the bed such that the patient is as far as physically possible from the X-ray emitter to reduce the amount of X-ray radiation the patient gets. That can be challenging in larger patients because there's just not a lot of space. We found using a phantom model that a C-arm with the emitter below versus a fixed table with the emitter above exposes patients to less radiation during ureteroscopy. We've also shown that obese patients are at much higher risk of higher doses of radiation. And again, it just has to do with the C-arm detects more tissue. It automatically increases the energy emitted, and basically those patients can get exposed to upwards of 2 to 3 times the amount of radiation. But we also adjust the bed throughout the case because if up and until the point I need to get my needle to get my access, I can leave the patient relatively close to the C-arm, and then we can lower the bed. I also make sure all my monitors are placed where I can clearly see them, so you're not wasting time getting redundant x-rays because you couldn't quite, oh wait, I can't see that. And so really the protocol starts with making sure that when it's appropriate, we use the low dose function on the C-arm. I think that's the first step that's often overlooked. Most C-arms literally have a button that just says low dose. And then only taking x-ray shots that we really need. I do very little live fluoroscopy during the case. We use a prone split leg, which I think is helpful for multiple reasons, one of which also can impact the amount of radiation that is used, in that you can place a ureteroscope into the kidney, which can also help you identify the calyx you want to enter, thus saving you time playing with fluoroscopy, trying to determine, oh, is this posterior or anterior? You can put a scope in, put some air through your scope, and just follow the bubbles. And the bubbles will all go posteriorly because it's up. And then place your ureteroscope in that calyx, take a single x-ray picture, go, oh, that's where we're going to puncture. And we use air as a contrast agent. And the reason for that is really threefold. One is it is white as opposed to the stone's gray, so you can very clearly see the stone throughout the case. Number two, it doesn't extravasate, meaning if you put your needle in and it's not in an accurate position, you don't end up with contrast around the kidney and obscuring your view. And then the third thing is several years ago we looked at our patients and found that air reduces the amount of radiation the patients are actually exposed to. And it has to do with how the C-arm works. So most modern C-arms automatically adjust. So air is less dense than contrast. The C-arm detects that. It realizes it needs to use less energy to create the similar image, and thereby the patient's exposed to less radiation. And we found that it was about roughly half compared to contrast for equivalent cases. Once we line the C-arm up over the kidney, we collimate down onto the kidney so that you're really only seeing what you need to see. The other benefit of collimation is it keeps your hands out of the field. So from a physician's perspective, it's a safety concern as well. In this case, we have two things that we can visualize to confirm we're in the right place. We have an open-ended catheter and a big stone. We inject our air, and that's the one time where I'll use live fluoroscopy because I want to see the anatomy as the air fills the kidney. Once we've done that, we determine which calyces we want to get our access. So we picked, in this case, a lower pole and an interpolar calyx based on the stone and based on the patient's anatomy. We place our wires in both access points before we dilate. So we will start in the lower pole. I use the bullseye technique to get my access. So we will rotate the C-arm towards us. Oftentimes that's another case where you use live fluoroscopy if you're trying to determine what's a posterior calyx. You can watch a posterior calyx move medially as you rotate the C-arm towards you. Once we have it lined up, we make a small incision, place our needle, make sure it's aligned, again using fluoroscopy, and then again I use live fluoroscopy as I advance the needle into the kidney. Once we feel we're at an appropriate depth, you rotate the C-arm back to check your depth, and then place our wires into that access. We then move on to our second access point and place our wires. I place the balloon, okay, quick picture, okay, I see my markers in the appropriate position, inflate. I just wait till I'm almost fully at the pressure I want to be before I check. Okay, good, there's no waste, ready to go. Sheath, I place my sheath. Again, I know roughly how far I need to go. Take a single picture to check my depth. If it's not quite far enough, I'll place it a little further, recheck my depth. Some people get like a confirmatory x-ray like after they take the balloon out. I think it's a waste of time in x-ray because quite frankly, I'm about to put a scope in. So I'm gonna know very quickly if I'm in the right place or not. So literally, for me, the last step is balloons inflated, sheaths in place. I tell my x-ray tech, pull the C-arm out. I tell my nurses to put my endoscopic image on all my monitors, take the balloon out, and I just look in. And if I'm not in the right spot, we could always bring the C-arm back in. So we'll dilate the lower pole tract, get out as much stone as we can, look around with a flexible endoscope. If there's clearly some stone left that's more burdensome that we just pull out, we'll dilate the second tract. And then again, using flexible endoscopy at the end of the case to look for residual fragments also helps reduce fluoroscopy because you could visually confirm whether the patient is stone-free. Once we are satisfied that the patient's stone-free, we bring a C-arm back in, and this is the one time where I will use a full dose image. So we'll ask them to turn low dose off, uncollimate the image, because now we're looking for residual fragments. So I think we will take a single image at first to see if there's any obvious stones. If there are obvious stones, then we go back in and try to get them. If there are no obvious stones, we often will grab one of the access sheaths and move it back and forth just to make sure that there's nothing adjacent to the tract, and we'll use a very brief amount of live fluoroscopy. And then basically, depending on how the case went, we'll determine what drainage tubes we leave. We do majority of our procedures tubeless, so we'll often place a double J stent or just leave the open-ended catheter. I think the take-home message is really being aware of the amount of fluoroscopy you're using during surgery and looking for opportunities where you can reduce it. Having that awareness, most people will be able to very quickly find ways to cut out radiation and start working their way down.